Would you like to hit record? Okay, thank you for joining us for our September webinar and happy NICU Awareness Month. I am Morgan Kowalski, FCC Task Force Program Manager and NICU parent of a 25-weeker who is now 7. For those of you who are joining us for the first time, I'd like to extend a warm welcome and remind all attendees that a recording of this webinar and all of the slides will be published on our website, fcctaskforce.org, as well as shared in a follow-up email, which we encourage you to share widely with your colleagues and network. Each of our webinars is dedicated to the NICU children of one of our speakers, and today we have the honor of dedicating this webinar to Megan Paulsen's sons, Peter and Nathaniel. Megan says, born at 25 weeks on St. Patrick's Day in 2019, they remind me every day why this work matters. Now 6 years old and freshly starting kindergarten, they embody resilience and joy in their own unique ways. Their journeys have shaped me as a physician and as a parent. Peter and Nathaniel, you are my greatest teachers. Thank you for sharing your family story with us, Megan. Your perspective as a parent is invaluable, and those boys are adorable. I'd like to take a moment to acknowledge that today is September 11th, a day of remembrance in the United States. We pause to honor the lives lost, the families forever changed, and the resilience of all those affected. Thank you for joining me and holding that in our thoughts today as we begin. Please take a moment to review our webinar etiquette. We ask that you mute your microphone when you aren't speaking, that you turn off your camera if you're multitasking, and that any questions and comments spoken or written in the chat be respectful, non-discriminatory, and non-judgmental. We appreciate your help in making this space as safe as possible. As a reminder, we follow the all-in meeting guidelines as created by our very own Jennifer Canvasser's Neck Society. For those of you who are attending for the first time, we use first names to address one another to break down the hierarchy that exists in healthcare and to empower everyone to contribute. I'd also like to acknowledge Mead Johnson Nutrition, whose mission is protect, heal, and nurture in pursuit of a healthier world. Thank you, MJN, for sponsoring this webinar, and congratulations to 120 years of leadership in pediatric nutrition. This work wouldn't be possible without our 52 esteemed organizational partnerships. A warm welcome to Alliance for Black NICU Families, Connected Forever, Cooper Steinhauser Foundation, Engage Grow Thrive, Georgia Perinatal Quality Collaborative, Glow Preemies, March of Dimes, National Association of Perinatal Social Workers, National Coalition for Infant Health, NICU alumni, and Texas Collaborative for Healthy Mothers and Babies. We appreciate relying on you all to share upcoming webinars, office hour sessions, and newsletters, and are grateful for the opportunity to spread the word about your events and achievements in the FCC world as well. It's incredible to see so many family-led organizations alongside healthcare professionals. And these partnerships is part of what makes the FCC Task Force so special. As we move on to FCC Task Force leadership, I'd like to acknowledge that our organization is led in equal partnership between healthcare professionals and family partners, which is one of our key strengths. Malathi Balasundaram and Colby Day are practicing neonatologists, and Kira Sorrells, founder and executive director of the NICU Parent Network, Colby and myself are former NICU parents. Thank you to our family partners for your contributions to our work. I love that we are diverse in our infants' gestational ages and diagnoses, and that we represent birthing, non-birthing, and bereaved parents. I'd also like to thank our healthcare partners for their time and support. It's rare in our local units to witness such authentic collaboration between the various disciplines of practice you represent, and we appreciate that you embody our key strength of equal partnership between all healthcare professionals and family partners. I'm excited to share that we've got over 2,600 members from 49 of 50 US states, 8 of 10 Canadian provinces, and from 71 countries around the world. Since our July webinar, we've welcomed over 200 members with representation from one new country, Cyprus. On to committee updates. Carrie and Nicole continue to work on the Present Study Toolkit creation, which will support NICUs in implementing unlimited parental presence, even in the face of a respiratory pathogen like COVID-19. We are grateful to Angel Eye Health for their support of this work. Jesse and Mia are creating a position paper to show our community where the Family-Centered Care Task Force stands on the importance of equity, diversity, inclusion, and belonging in the NICU. They plan to create informal guidelines or toolkit around ensuring nonverbal messaging or silent signals in the NICU are consistent with FCC values and bring an EDIB lens to our work to ensure it's reflective of our commitment to health equity. Daphna and Alex are busy sharing FCC Task Force related events, resources, advocacy opportunities, and education on our social media platforms. Please take a moment to follow us. Our domains are linked on the homepage and footer of our website, as well as at the bottom of email correspondence. We invite you to tag us in your FCC related content so that we can easily share and promote your important work. The newsletter committee will release its fall publication in the coming weeks with a quarterly ARIAS journey, supporting families beyond discharge, a summary of today's webinar and related resources, trauma-informed care corner, and FCC Task Force Executive Council update. It's worth repeating that units who share our newsletter with their colleagues and who print and post them in their staff spaces are reporting increased success obtaining buy-in around family-centered care practices. This month's poll asks for your feedback. Please share what you love about FCC Task Force, where we can improve, and what we can offer to help your NICU implement FCC. If you have an idea for our next poll, please email me. Poll questions are submitted by members and answered by members, and we want to hear from you. If you haven't joined us for a free monthly office hours session, I invite you to do so. These are an informal opportunity to share your unit's barriers to implementing FCC practices in a safe space. Brainstorm with FCC Task Force leadership and your peers on a variety of topics, including collaborating with parents, recruiting families for a family partnership council, discharge planning, and more. We have presented 21 webinars so far, with this being our 22nd. Please utilize our webinar database located on our website under both the Webinars and Resources tabs to view and share all past FCC Task Force webinars. We encourage you to share these widely with your colleagues and invite you to subscribe to our YouTube channel so you can be the first to know when we upload a new webinar recording. We invite you to register for the 39th Annual Gravens Conference, Sensitive Issues in Sensational Times. While the date and location of this amazing event is changing, you can expect the same great topics, workshops, abstracts, and networking opportunities for those who work in the NICU space. I'll drop a link in the chat where you can explore the Gravens Conference website to register and learn more about abstract submission. In January of this year, we asked if your unit screens for NICU families for perinatal mood disorders and anxiety disorders. If you're listening in from a unit that doesn't screen NICU families, today's presentations will be your guide. I'll pass it over to our co-chair and the founder and executive director of the NICU Parent Network, Kira Sorrells, to introduce our first speakers.
Thanks, Morgan, and welcome everybody. I am delighted to introduce Sarah Swenson and Megan Paulsen for the first part of our webinar today. Sarah is an assistant professor in the Division of Neonatology at the University of Nebraska College of Medicine, Department of Pediatrics and Children's Nebraska. Her work combines advocacy, quality improvement, and research to enhance opportunities for well-being for families impacted by neonatal intensive care. She led quality improvement initiatives at the University of Minnesota and Children's Minnesota to implement standardized longitudinal perinatal mental health screening for parents of infants hospitalized in neonatal intensive care units during her neonatal perinatal medicine fellowship. We're so glad to have you with us today, Sarah. And Megan Paulsen is a neonatologist at Children's Minnesota and adjunct assistant professor of pediatrics at the University of Minnesota. Her academic focus includes systems-based quality improvement, patient-family experience, and parent-oriented outcomes of infants born extremely preterm. Dr. Paulsen is the mother of Peter and Nathaniel, born at 25 weeks gestation in 2019. She's authored perspective pieces and delivered regional and national presentations on her experience as a NICU parent. Her perspective as both a neonatologist and a former NICU parent uniquely informs her commitment to advancing interdisciplinary trauma-informed approaches to neonatal and perinatal care. Thank you so much for being with us. I will turn it now over to our speakers.
Thank you so much. Is everyone seeing the slides okay still? I really appreciate the invitation to be here and for the kind introduction. It's really exciting to share this work and to get feedback as we try to improve family-centered care through supporting parent mental health. Briefly, this is what we're planning to talk about today, starting first and most importantly with Megan's story.
Thank you for the opportunity to share my story today. I've learned that the more I share, the more I heal, and the more purpose I find in this journey. But today I'm here not as a physician, but as a NICU mom who discovered that outcomes are about far more than survival statistics. Before I was a NICU parent, I was a neonatologist. My husband and I went through years of infertility and IVF, transferred our last 2 embryos, and both fortunately implanted. 6 months later, our boys arrived at 25 weeks. I knew every statistic, but nothing prepared me for the reality of ventilators breathing for them, infections, surgeries, and the uncertainty of whether they would ever come home. Those months were terrifying. They reshaped how I understood outcomes, not just as a physician, but as a parent. 10 weeks into our stay, I held Nathaniel when he aspirated and turned blue in my arms. Within seconds, the room filled with clinicians, and he recovered quickly. From a physician lens, this was routine, but as his mother, I froze in terror. I backed into a corner, sobbing. I had led dozens of codes, but in that moment, I couldn't move. What shocked me wasn't the event, but it was my response, the panic, that shame, that showed me something I hadn't grasped before, that NICU outcomes aren't just about babies, they're about parents too. After discharge, my boys were thriving. They discharged home around their due date on oxygen and medications and had follow-up appointments. We had every possible resource, family, church, financial security, even help at home. From the outside, it looked like we had it together, but inside it was chaos. The boys' room was pristine, but the rest of the house mirrored our unraveling. I stopped answering calls. I dreaded going back to work. I carried guilt for past patients and anticipatory guilt for the ones I would care for again. I had nightmares, flashbacks, and rage. It wasn't just guilt, it was despair. My boys had survived, but I felt like I was failing them at home, and that's when I realized I needed help. On paper, my boys were a success story. No IVH, no NEC, no devastating morbidities. And I am so grateful. I don't want that to be missed. But my outcomes as a parent looked very different. Could I bond with them? Could I sleep without panic? Could we carry the burdens of endless visits, financial strain, and emotional exhaustion? These are outcomes we don't capture. We don't track the isolation, the shame, and the toll on marriages. Yet these invisible outcomes shape whether families not only survive the NICU, but thrive after it. My story is also shaped by privilege. I am white, I am a physician, I am financially secure, and I have strong family support. Even with all of that, the NICU nearly broke me. I think often of families without these supports, those facing racism, language barriers, and housing insecurity. These are the very families at highest risk for NICU admission and poor outcomes, and their invisible wounds are even heavier. Equity must be at the center of how we think about family mental health. What helped us were the small things: a nurse who encouraged skin to skin, a social worker who simply sat with me, a faith community that showed up, friends who traveled to be by our side, and eventually therapy and medical treatment. These lifelines mattered. But what was missing was a system, No one screened me for PTSD. No one asked my husband how he was doing. Parents are taught to run oxygen and give medications, but not how to manage the fear that lives in their bones. And we know my story is not unique. Rates of depression and anxiety in NICU parents are 2 to 5 times higher than the general population, yet fewer than 1 in 5 mothers and 1 in 10 fathers access help on their own. Father symptoms improve when they do, but too often they're never asked. Parent mental health is not extra. It is neuroprotective care. Just as skin to skin and breast milk protect babies, so does parent well-being. The next frontier is embedding the truth into our systems, routine screening for depression, anxiety, PTSD during and after NICU stays, including fathers and partners, embedding social work, psychology, peer mentors as part of standard care, and not optional referrals. Outcomes should mean families leave the NICU intact, supported, and able to thrive at home. I began with the night Nathaniel aspirated in my arms. Clinically, he was fine. But that moment broke me open and revealed the invisible wounds we rarely talk about. Today, Peter and Nathaniel are thriving, resilient, and joyful, and I'm still healing. What I know now is this: the next frontier in neonatology isn't about saving babies, it's about saving families as well. Because when parents heal, families thrive. And when families thrive, so do the children we fought so hard to save. Thank you for listening to my story.
Thank you, Megan. I feel like I have to just take a second to collect myself. It's such a powerful story, and we're so lucky that you share it with us. It's so important to remember why we need to be doing this work to better support parents. As many of you know, Megan's story is not unique. Perinatal mental health concerns are common, and not enough parents are getting the help that they need. Unfortunately, perinatal mental health concerns are the leading cause of pregnancy-related death. It's not only important to treat perinatal mental health concerns because it's the right thing to do by parents, it's also important because untreated parent mental health disorders have been recognized as an adverse childhood experience with potential lifelong impacts. Because parents often interact with their pediatricians more than their own providers, the AAP has recommended parent mental health screening by pediatricians for the benefit of the child. As a pediatric resident, when the AAP policy statement recommended routine postpartum depression screening at infant well child checks in 2019, I was used to screening moms for mental health symptoms when caring for their infants. But what surprised me was that we weren't also screening in the NICU, where parents are at increased risk for mental health symptoms. Moreover, I knew from talking to parents and from emerging data that partners were also often experiencing mental health symptoms, but were less likely to receive support. So we began this work with the goal of implementing inclusive screening for all parents in the NICU. Since we've started this work, the AAP has recommended depression screening for NICU families as part of the 2023 neonatal standards of care, making it all the more important that we figure out how to do this work effectively. There really has not been enough attention paid to the mental health of partners, and where there has been, it's been limited to dads. In this study, you can see that when looking at the general population and screening dads who attended postpartum primary care clinic visits, 30% of those dads screened positive. And also important to note, 26% of them were uninsured and 54% did not have primary care providers. This suggests that dads are unlikely to have their symptoms identified and have the ability to receive treatment if they're not screened within pediatric settings. Moreover, there's evidence that when dads have postpartum depression, children are twice as likely to experience 3 or more adverse childhood experiences by the time they're 5. And here you can see just how high the risks for NICU parents are, with approximately 50% impacted by anxiety, a similar number impacted by depression, up to 70% affected by acute stress disorder, and 80% having at one of these concerns. It's also important to acknowledge, like Megan said, that there are disparities in mental health outcomes in the perinatal period. Evidence has shown that birthing people from marginalized populations are at increased risk for preterm birth, as well as mental health concerns. there's evidence that Black parents of preterm infants are more likely to have a mental health related emergency room visit or hospitalization. And this suggests that an equity lens is necessary in research and quality improvement on perinatal mental health to ensure that equitable screening happens and that there's equitable access to mental health care as well. This is a slide from Kazak et al. It shows an example of how we can use screening to distinguish which parents need targeted intervention or clinical treatment. Although all families need some degree of universal support, the highest risk families will benefit from targeted interventions. But many of these families are missed without universal screening because they suffer silently. Gaps remain in our understanding of the needs of parents in the NICU related to mental health, as well as the best ways to support their mental health through screening, some of which I've highlighted here. There have been 2 recent surveys to understand the prevalence of routine mental health screening in NICU settings. In the most recent, which was a study of NICUs within CHNC, less than half of responding centers reported screening parents for mental health concerns using a validated tool, and only 38% had psychologists within their NICUs to provide parents with mental health support. An earlier study didn't specify whether validated tools were used as part of what they considered routine screening, but still less than half of the respondents reported routinely screening parents for mental health concerns. And when they did, less than half included fathers or partners. Almost a quarter did not provide parents with any mental health screening, and community NICUs were less likely to screen compared to academic centers. Only 11% had integrated psychologists within the NICU, and a minority felt that they had adequate psychosocial support within their units. And so I found myself training at one of the many NICUs that was not screening parents for mental health symptoms using a validated tool. And my initial goal in this work was to improve local mental health support for families while they were in the NICU through the implementation of routine mental health screening. I also hope that through this work, we'd be able to inform further interventions and garner more resources for families locally. So next, I'll talk briefly about my initial work to implement screening in a level 4 NICU. To do this project, we organized a multidisciplinary team inclusive of former NICU parents. Our pre-intervention data was collected over a 6-month period and included social work tracking of parents whom they were referring for further assessment for mental health symptoms based on their informal assessments. I used our system's Well Child Clinic depression screening protocol as a guide when building our NICU screening program. And I also reviewed screening protocols from existing NICU screening programs that Dr. Mike Heinen helped connect me to. I saw he was on the call today, so thank you again for doing that. We implemented longitudinal standardized screening using the Edinburgh Postnatal Depression Scale and its anxiety subscale, with thresholds for referral indicated here. Screening was performed by the social work team per their preference and also to make the referral process as efficient as possible. Referrals were made to mental health providers, primary care providers, or both, according to our screening algorithm. Social work team members continued to refer parents based on informal assessments outside of the screening intervals. We aim to screen all families at least once, even if they were followed for mental health symptoms, but parents who were receiving mental health care were exempt from further screening unless it was felt to be clinically indicated, which mirrored the outpatient policy. We also surveyed parents in NICU follow-up visits, those attending before we began screening and those after, to understand their perceptions of mental health support. We implemented this program using quality improvement methodology. Our specific aim was to implement standardized longitudinal mental health screening for parents of infants hospitalized in the NICU at the AAP recommended intervals of 1, 2, 4, and 6 months, and to achieve at least 70% screen completion, up from our baseline of 0% within 6 months. Here, I briefly list the outcome and process measures, and here are the balancing measures that I'm happy to talk more about. Next, I'll go to the results and highlight some of the major lessons we learned as I go. Here you can see that we increased screening rates from a baseline of 0 to 77% when looking at all parents. And we also separated our run charts by parent type and found that screen completion rate for mothers was 80% versus 72% for partners. So although we know that partners are often more difficult to reach for screening, given they usually have more barriers to being at bedside, we demonstrated that the majority could be reached for screening and were willing to complete screens. I was asked when I was writing this up about screen completion rates by intervals, and here you can see that they're favorably stable across time, though actually higher, especially for mothers at 4 months and 6 months, indicating that it wasn't more difficult to screen parents as time went on, even though we know that's a period where more and more parents need to go back to work. This is a comparison of the 6-month period. So using clinical interactions alone, we identified 52 parents with mental health concerns in a 6-month period. And that is compared to 60 parents when we did standardized screening. Although those numbers look similar, that doesn't include that informal assessments continued, but were not measured in the screening period. So we'd estimate that the total referrals would actually be higher. One surprising finding in lesson number 1 was that 73% of the concerns detected through routine clinical interactions were identified within the first week after birth. And we posit that this is because parents may have more interactions with the social work team in the days following admission compared to later in the NICU stay. When we looked at later time points, we see that informal assessments only identified 12 concerns at or after 1 month compared to 60 in the standardized screening program, which was lesson number 2. A similar percent of parents in both periods who were referred had established mental health care providers, suggesting this wasn't just later detection of symptoms, but potentially helpful in identifying parents with significant symptoms who are not yet receiving mental health care. We also found that more parents who were identified through screening to be experiencing suicidal ideation, which for our parents was evaluated to be passive, but we did have an escalation of care policy if parents disclosed active suicide ideation or any other mental health crisis. One gap in our program was that only 77% of the parents who had a score above threshold for referral were referred as recommended by our algorithm, and missed referrals were most frequent when scores were near the threshold for referral. Screening increased the percent of concerns identified in partners 5-fold. So lesson 3 was that the needs of partners are unlikely to be met without systematic attention to their inclusion within the NICU. The fact that informal screening did not detect many concerns 1 month or more after birth is especially concerning, given our finding that mental health needs increased in parents with prolonged NICU stays, which was lesson number 4. And the high proportion of positive screens at 4 and 6 months suggests the need for repeat screening in the inpatient setting. I'm especially interested in how we might optimize our healthcare systems in the future to better support families in these circumstances. The need for more support later in the NICU stay was reaffirmed in our pre-screening implementation surveys, where we saw a common theme when parents were asked open-ended questions about what was or wasn't working for NICU families related to the support they received. For example, one parent said, "I wish there was more mental health support in the last weeks of admission and in follow-ups for a few months after discharge. Those first few months on the high acuity unit were just a blur. It wasn't until later in the stay and immediately after discharge that I needed support." Another said, "We didn't feel like the social worker helped much at the end of our journey." And a parent on our QI team said, "I probably needed mental health support when my baby was in the NICU, but I definitely needed it after they came home." Of the parents who returned surveys on perceptions of screening, the majority viewed screening as valuable. Anecdotally, I was also stopped more than once by parents who asked if I was the person responsible for mental health screening, thanking me and identifying it as an area of importance. Some parents wrote things like, "Thank you for asking," on the bottom of our screens or surveys. Only 11% found screening difficult. We also looked at the number of parents who explicitly declined screening or social work involvement, which was low at 2%. To further assess parent perceptions of screening, I designed this survey to be given to all parents at NICU follow-up visits, again, pre-implementation of screening, and then 1 year later. This was translated into English, Spanish, Somali, and Hmong, and asked questions about parent experiences with NICU-related stress and related support. So some people wonder, should you wait to screen until you have the perfect referral system and resources available to parents? I think it's an important question. And I also wanted to know that screening wasn't just making us feel better and checking a box, but that it was actually impacting parent support. So here you can see, comparing pre to post screening implementation surveys, that preliminary data suggests that perceptions of support after implementation to the mental health screening, with an average answer closer to 1, or strongly agree to questions asking that the team with them, that they received adequate mental health resources, and that they received adequate mental health referrals. This was in a system without embedded support. Instead, the SOL team would help facilitate referrals to psychologists in the community, using resources such as Postpartum Support International when needed to identify a provider for a particular insurance type, or if parents needed care closer to home. They recommended visits with OBs or primary care providers when mental health visits could not be made in a timely fashion, or if parents did not want to see a mental health professional. We also gave all families resources, including the Postpartum Support International Helpline, the Maternal Mental Health Hotline, and National Suicide Crisis numbers. Therefore, while I think we need to be careful that we aren't just screening to check a box, as we know that's unlikely to have a positive impact on families, I do think that screening is important and should not be postponed while we attempt to build even better systems of support. In part, better systems may be more likely when we have local data to support advocacy for what we need. We also asked parents to leave comments about what was or wasn't working, about how we supported them during the NICU admission. And of the 22 surveys completed, 9 left comments that fell into the following categories. So in addition to more mental health support later in the NICU stay, things like bedside cameras, private rooms, primary nurses, the unrestricted family presence, parent champions are all things that might give us more ideas for institutional advocacy. Further focus groups, interviews, surveys in partnership with parent advocacy groups and community partners may be beneficial to better understand how we can support family well-being and connection in the NICU. Provider perceptions of screening were overwhelmingly positive in terms of value. However, the workload associated with screening was perceived by the social work team as more unmanageable over time, especially after unexpected leaves of absences meant that only 2 NICU social workers were covering a unit that's usually covered by 5. So lesson 5 was that NICUs likely need additional psychosocial team members to support effective perinatal mental health screening. And I used the local data to move this further by involving more collaboration with child and adult psychologists who worked toward embedding more services within the NICU. There are several limitations of the data, some of which include that our screening rate was not 100%, that we know some parents might not disclose mental health symptoms through screening, that parents appear in my data set more than once. Our baseline data relied on a social work team, which might underestimate or overestimate the amount of concerns that they reported being detected outside of screening, and that we are unable to track concerns detected outside of screening during the screening period. There are also limitations to our pilot screening program, including that we did not assess trauma symptoms, that we did not screen post-discharge, and that we were not able to track whether parents were receiving mental health care after referral, and that should be next steps for this work. In addition, we can talk about more things we can do moving forward to build upon this work. So first, let's talk about the timing of screening. Standardized screening appears to be especially beneficial in identifying parents with mental health symptoms beyond the first few weeks of admission, when interactions with the social work team may be less frequent. Longitudinal screening appears to be important, as the initial screen may miss symptoms that develop later in the NICU stay. But we need to work with parents to understand their perspectives and determine a frequency of screening that maximizes detection of symptoms and facilitates early intervention without being so frequent as to become burdensome. Second, we need to systematically include partners. The mental health of all parents is vital. We found that we are missing partners with mental health concerns when we relied on clinical interactions with them, and the use of validated tools should be considered with attempts to screen universally. This is especially important because partners are not routinely screened after NICU discharge during well child visits. An AAP resolution, which I helped to pass this year, asks the AAP to explicitly include partners in screening recommendations in the NICU, and to also include them in the next AAP policy statement on postpartum depression screening at well child visits. We must also recognize that partner mental health is further stigmatized by less frequent discussion, and many resources such as the maternal mental health hotline accepts calls from partners, but the name alone may discourage partners from receiving the support they need through these resources. The workload associated with screening reported by the social work team must also be highlighted. Additional personnel are likely needed for screening programs to be successful in the long term, which is something that's been recommended by others. And acknowledging that the ultimate goal of screening is to connect parents with mental health symptoms to health care. Some have recommended the availability of psychotherapy within units. If this doesn't sound aspirational enough to you, I'll also add that the support should be available at no cost to parents to remove cost as a barrier to care. And we have a lot to do within our systems to make this a reality. Lastly, I posit that electronic screening may be beneficial compared to paper screening, although parent perspectives will be important to understand before implementing. Possible benefits may include improved accuracy of algorithm adherence, especially if you're using multiple screens with different thresholds for referral, decreasing the time between screen completion and discussion of screening results with a psychosocial team member, decreasing the workload associated with screening, and possibly improving screen completion rate. With that, I'd like to thank the many people who have helped with this work and highlight especially the medical students and residents who helped me with this project. Thank you again for the opportunity to share this work. I'm happy to take any questions, feedback, or perspectives on what directions you feel we should take to improve the standard of care for mental health support in the NICU. Thank you.
Thank you, Sarah, and thank you so much, Meg, for sharing your experiences. We did have some questions that came through in the chat box. One of them had to do with how the screening was documented. Was that in the infant's chart or some other location?
Yeah, it's a good question. And in the paper that I recently published about our implementation, I go over this in more detail. We did chart within parent charts when they existed within our system, and in discussion with risk management and legal, because some babies came into our system without having a chart in the system, or especially for partners, not all of them, even if they were inborn, had charts within our system. We used confidential notes in and legal team, and in keeping with both HIPAA and our state law, which is more restrictive than to run your the risk and legal team. And I would say that the gold standard that we're creating parent charts and charting in the parent chart where possible. That was a next step for our work.
Thank you so much. And another question had to do with how do you overcome barriers for implementation? What are some of your thoughts on that?
It depends what barriers you're talking about, because there's many different, institutional, legal, getting the team on board, getting the social work team on board if you're using social work led screening, getting the nurses on board if you're doing nursing led screening. There are just so many barriers that it's hard to talk about them on the whole. We do have through the CHNC a PMAD focus group, and we're doing a workshop this fall at the CHNC conference, a pre-symposium workshop that is aiming to help programs work through some of their local barriers.
And then we also had a question, how to best choose screening tools given the various options, and were there other screening tools that you considered?
Yeah, that's a great question. We used a screening tool that was used in the outpatient setting as a starting point. You can see through the literature, that various depression tools have been used, various anxiety tools have been used, and then there's also trauma tools that are being used in the NICU. Since we weren't doing trauma in this initial pilot, we just used the screen in keeping with our outpatient practices, which was the Edinburgh. We rolled out actually at within two hospital systems in the Twin Cities, and the other one was using the PHQ-9 in their pediatric well visit screening and in their OB screening prenatally. So we initially rolled out with the PHQ-9 and the GAD-7 in keeping with that system. So I recommend that as a place to start. But there's also a wealth of literature and psychologists who could advise on the pros and cons of various tools.
Do we have any other questions? Malathi or Morgan, did you have any questions before we move on to the next portion?
I don't have questions, but I did want to say how much I love that you translated this screening into multiple languages in addition to Spanish. So well done. That's great.
Yeah, I think an area for further work, we'll be looking at, even though the Edinburgh and other screens are validated in other languages, and we use those where possible. We did see sometimes parents put a question mark, especially next to the question that about things are getting on top of me. And so even though might be validated, translated versions of some of these surveys, I think there's more work to be done to understand whether they're actually working well for these populations.
I see Sue has her hand up. You can go ahead and ask your question, Sue. And then we did have.
I just had a question. And I don't know if everybody's doing it or how you did it. We just finished a project here in Florida on looking at some of this, not quite as in-depth as you did. And one of the things that we looked at, what were the mental health screenings. But what I was really curious about is a lot of our hospitals would just use the original L&D because they would come in, they would get their screening in L&D, they would get their Edinburgh, or most of us were using the Edinburgh, and then they'd come to the NICU and we would find out that there wasn't any screening. So we actually implemented some trauma-informed care education with our nurses so that they could at least then make referrals. And I was wondering if other places were doing that, because one of the things we found out is we've got to educate the nurses at the bedside because they're going to see it far before anybody else. We actually brought Mary Coughlin in to do a whole day training with us on trauma-informed care. And I saw that Michael was on, and he was the very first person who ever made me realize about trauma, because he talked about his 45, I still remember this, about having to go in and wash his hands in the NICU up to his elbow and nobody telling him he had to rinse his arms off and dry them off. I still remember that story, and how your wife would panic at night when the phone would ring. So I just wanted to mention that, but really that's what we found, is that we needed to do more education with the nurses. We could not leave it to the social workers. And so few of our hospitals have neonatal psychologists. I mean, I wish we did, but we didn't.
Yeah. Thank you, Sue. Morgan, do we have time for any more questions, or is it time to move along?
Why don't we go ahead and introduce our next speakers, if that's okay. Any other questions? If you'd like, you can email me and I will be sure to pass them along, and we'll get an answer and include that in the follow-up email with the webinar recording and slides. Malathi, are you on to introduce next speakers? If not, I can do so. All right, looks like it's me. So our next speakers are Michelle Kelly and Lauren Ingledow. Michelle is professor and co-director of the Mid-Atlantic Center for Children's Health and the Environment at Villanova University's University M. Louise Fitzpatrick College of Nursing. Michelle is a fellow in the American Academy of Nursing and the American Association of Nurse Practitioners. Her research centers on preterm birth outcomes, exploring the link between preterm birth and future health complicated by environmental exposures, poverty, and toxic stress. She is a dual certified pediatric and neonatal nurse practitioner with over 25 years of experience providing care to children of all ages in a variety of settings. Lauren Ingledow was born in 1988 at 26 weeks gestation and weighing 430 grams due to preeclampsia. Lauren achieved a BSc in Applied Animal Studies and is a qualified canine hydrotherapist. Lauren is co-founder and director of the Adult Preemie Advocacy Network. Thank you, Lauren, for being an organizational partner of the FCC Task Force. The Adult Preemie Advocacy Network was formed in 2021 by a group of adults who were born prematurely. Beginning as a space to share experiences, this grew to a realization of the need for advocacy around long-term outcomes. This is accomplished by combining scientific evidence with lived experiences to promote awareness and understanding of the lifelong physical and psychological impact of premature birth. The network aims include providing a global network of peer support and raising awareness through their website, social media, and national/international speaking events. Thank you both so much for your time today, and I'll let you take it away.
Okay, are you seeing my screen?
Yes.
Okay, excellent. So thank you for giving me the opportunity and Lauren the opportunity to join you today. Lauren and I sort of do this as a tag team, and we've done lots of different versions of this talk. And I hope what we share today is helpful to all of you. So I don't have any disclosures, but I do in general come with a warning label. I am going to try really hard to get you to think a little bit differently about preterm birth. Think outside of the NICU. As a neonatal and pediatric nurse practitioner, when I first started, my career started as a pediatric nurse practitioner. I moved into the NICU. I realized, holy moly, I don't know what happens in the NICU, and they sure as hell don't know what happens, in the NICU. So that sort of started where my research started, and over time, when I realized that my preemies grow up, I realized I had an obligation to really sort of delve into what happens next. I'm in my 50s. I was educated as a nurse in the early 1990s. I became a nurse practitioner by the late 1990s, and a neonatal nurse practitioner in the early 2000s. So when I was educated, when I received my medical, my nurse advanced practice education, these were kind of the myths, right? All children catch up by age 2. If they don't catch up by 2, it's obvious and you'll know it. Preterm birth only matters till about 4. Don't worry about it after that. And those 32, 34 weekers, they're not really preemies, right? That's sort of that mentality that the primary care folks work within. And we know that these myths are not true. They are no longer true. And when I speak with adults who were born preterm, one of the concerns that they have is, well, why didn't anybody know? Well, why didn't people tell me? Well, why didn't? Well, quite frankly, to the 40-year-old preemies or the 50-year-old preemies, we didn't know then, but we do know now, right? So this is all evolving science. And so I'm going to try and shift your brains a little bit and work towards a different paradigm. This is my other favorite quote from people who I have given any version of this lecture to, right, or this talk to. Yeah, they were born early, but we can't do anything about that, so let's not worry about it. Or the other one I hear is, well, we don't treat it any differently. If they have, attention deficit or hypertension, we're not going to do anything differently. So why does it matter where it came from? Why does it matter why it started? Well, my pushback to that is, well, we ask about family history of smoking. We ask about family history of heart disease. We ask about diabetes. I can't change family history, but I can use that in my risk assessments. I can use it in my anticipatory guidance, and I can use it in treatment and planning. So that's the paradigm shift that I have spent the last couple of years banging the drum about. And just to show that I'm not making this all up, right? In 2016 or 2015, actually, there was an NIH conference that was put together, the adults born preterm epidemiology and biologic basis for adult outcomes. There are about 60 authors of this report. Those 60 authors and maybe 5 other of us have ever read this. I don't think the general practice environment really knows that this exists, but it was published in 2017 and shows some pretty, some pretty hard and fast evidence that preterm birth matters across the lifespan, not because it's a foregone conclusion of that there will be deficits, but that there are risks, right? And I am always very, very deliberate about speaking about risks and ways to mitigate risks, not about absolutes, right? Because the environment, the resources, all of that is going to play into how those risks are expressed. And I just need to read this this one piece out of this. It says, this was the conclusion. There's an urgent need to increase awareness among healthcare providers about outcomes for those born preterm at all gestations, because it may inform an understanding of disease and adequacy of response to interventions in this group. Communication between parents, teachers, healthcare professionals is needed to increase the appreciation for a preterm born child's educational, behavioral, and psychosocial risks. So there it is, right? Tansi Raju came out and said it, right? And we're still not really doing it. So what are those risks that I'm talking about? Well, from a pulmonary standpoint, we know that people born early have higher rates of wheezing, whether or not they had BPD. That wheezing worsens with excessive weight gain in the first year of life. And as people age, we have a decreased pulmonary function and increased airflow obstruction. There's a 2023 study out of Australia by Smith and colleagues, and they determined that between 9 and 12 years of age, about 32% of their sample that did not have BPD, and about 59% of their sample that did have BPD had a respiratory admission in their early years, in their early childhood. And that just one early life respiratory admission post the NICU was associated with reduced peak lung function and increased prebronchial thickening in those patients. So that early management of their respiratory conditions is really important. They also found in their sample a 2-fold increase of COPD in middle age in their population. So, when we in the NICU, we think so much and we're so focused on making sure that we're, gentle ventilation and protecting and retaining lung and lung growth and all of this stuff that happens right here. But the kids that go home without oxygen, the kids that go home, with just maybe minor support, they're still a population that needs to be followed. And I spoke at the CHOP BPD conference with Lauren last year. And, here's me preaching to the choir of neonatologists and pulmonologists, but they actually, were like, well, we're not thinking about it afterwards, right? So it's that long-term stuff. And I know most of you are NICU providers, and I'm going to tell you why it's important. So just bear with me for a minute, why it's important to get this message to you guys as well. Cardiovascularly, we also have elevated systolic blood pressures, particularly in females, increased risk of diabetes and hypertension. Mental and behavioral health, we do know that we have increased risks of anxiety, depression, attention deficit disorder. That attention deficit disorder in a child born preterm is typically the inattentive type, which means that they are typically not the child in school that is getting a whole lot of attention, right? Because they're the inattentive type, they don't disrupt the classroom, so they just get passed along, right? And while not all of this evidence about, some of the mental health and behavioral issues is rock solid, what it is a confirmation of risk, right? So these are all things that are responsive to intervention. We can modify this risk. And when I'm wearing my environmental health hat, we talk a lot about environmental risks associated with some of these pulmonary conditions, with their cardiovascular conditions, as well as with the mental health and neurocognitive conditions. We do know that kids that are born early do have increased rates of special education. Some have difficulties with math and reading, some impaired receptive vocabulary and language skills. But again, this risk can be seen in not just our smallest children, but across moderate and late term preterms as well. And intervention and environment matter, right? We can, if we support our families well, through early childhood and into adolescence, we can really make a difference. Okay, so what does a nurse researcher who sees all this and doesn't know what to do about it, and how do I change practice? Well, I wrote a set of guidelines. I put together a clinical practice recommendations for addressing preterm birth across the lifespan. They are basic. They are a starting point. They were published in 2021. They already probably need to be revised, because there's some good cardiovascular literature coming out that may direct some of the interventions. And there's also some really good pulmonary stuff that the BPD collaborative is working towards. So this is a start, and it's a way to start to get us thinking differently, and changing the message with our primary care and pediatric primary care through adult primary care colleagues, in terms of how we can help support our kids born early from the start. So I told you I was going to come up with something for you all to do, right? What's your role in this? Well, you're the folks they trust the most, right? The NICU team is hands down the group that our parents trust and look to for advice and level setting. So I would love to see somewhere after this, right? We're not having these conversations here at this stage, right? But somewhere when we get to here, when we're talking in those slow weeks where we're talking about getting those kids ready to go home, let's change our message from "you're all good, we're out of the NICU, good luck and God bless," to let's talk about, what are the things that I want you to continue to tell your primary care providers, right? We know there is not enough NICU follow-up across the United States. NICU follow-up is a privilege. It's an opportunity. It's an event that only happens in certain communities and certain areas. And if we're lucky, even those areas only get it until 2 or 4, right? So how can we change the messaging so that we remind our families that, hey, your kid's doing great, and I want you to continue to expect your child to do great, but remind the teacher that your child was born early, right? I am the parent of 3. You do in elementary school, you do the parent homework assignment that says, in a million words or less, tell me what I need to know about your child. Well, I tell them to say this. My son was born at 30 weeks. He's doing great. I expect him to keep meeting all of his milestones. But if you have concerns, I'd really like you to let me know, right? Because in focus groups with teachers, what I learned was that most teachers will overlook the first struggle. So the child who drops a math level or a reading level in school, we don't get intervention involved. We don't get things, that doesn't trigger something. Because we're waiting for that next time, because maybe this was a fluke, maybe they'll catch up, right? But if we added that risk part of, he was born at 30 weeks. And so perhaps we add those two pieces together. So maybe we trigger a further evaluation. Maybe we trigger some reading support or some learning support. Now, again, that's all about resources. And, schools will look at me like I'm, they want to strangle me when I say, we should start paying more attention to this, because it does take resources to get there. But if we want these guys to go from here to here, we really need to maximize their abilities and really support them in the best way we can. It's a work in progress, right? I have been, working on this, and the work that Lauren and I have done in terms of we hopefully have a qualitative paper coming out soon that really does tell a fantastic story about the experience of adults that were born early and how we can support them best. So I am going to turn it over to Lauren now because her story is just amazing, and all the work that she's done, and we'll take questions towards the end.
Lovely. Can everybody see my screen and hear me okay? Yeah, lovely. So a little bit about me. I was born at 26 weeks gestation and weighing 430 grams due to preeclampsia. I had a medical follow-up at 3 years old. And this checked for closure of my PDA. My screen's frozen. Has it come back again? Is it okay? Yeah, lovely, thanks. Okay, so I had a medical check at 3 to make sure the PDA had closed and I didn't have a heart murmur. I passed that with flying colours. And something that's become really apparent to me over the years is that importance of confidence in communication between parents and carers and the offspring about your prematurity. So it's really relatively recently that I sat back and I thought, Mum, when I had my follow-up at 3, what did they actually look for? Was it holistic? Did they look at lots of things? And my mum's answer was no, it really wasn't. It was purely a heart check and you were discharged with flying colours. So after I was discharged, my mum quite routinely took me to our primary healthcare provider because I had reasonably recurrent throat and chest infections. But during that time, she also tried to discuss the possibility of ongoing monitoring and follow-up. But she really hit a brick wall with that narrative. And she said that her concerns were really dismissed, and that in the end, healthcare providers were suggesting that she was over-anxious and that she had mental health problems. And my mum admitted that from that point onward, she could see the track that this was going, and admits that to an extent she stopped advocating because the emphasis was on her and perhaps this over-anxiousness compared to genuine concerns that I had been born early, and that whilst we didn't know what the future looked like, was it worth monitoring going forward? So I was very lucky throughout childhood and into adolescence that main issues were throat and chest infections, things like energy levels and sleep. And whilst this did impact me on a personal level, and there was awareness within my family, it really wasn't considered serious enough to warrant further investigation. This changed quite suddenly in adulthood at 26 years old, where quite suddenly I lost 6 kilos in weight and was becoming extremely fatigued. And this was really unexpected because at the time I was still working as a swimming dogs, so I had a very physical job. And no one really knew what was going on. So I went to primary care. They acknowledged that I didn't seem to have a blood test on my records. So decided to do a full screening. And this is where it started to flag that I had type 2 diabetes and chronic kidney disease. And this really took my family in complete shock. Because my blood test levels were high but borderline threshold, it became very difficult for me to be referred to a consultant. It was something that my primary care provider agreed that needed to happen because something was going on, but was very difficult to achieve without my mum stepping in to advocate for me. And it was only during this consultation with the kidney specialist that my mum shared that I was born due to preeclampsia, I was early, I had low birth weight, and the consultant shared that actually, if you're born early, your gestation can dictate the number of nephrons that you have in your kidneys, and that was possibly playing a role alongside possibly a virus trigger, things like chronic insomnia and stress. And it's quite difficult to explain the impact that this had on my mum. My abiding memory of that period of time is driving home from that initial kidney consultation and having to ask my mum to pull over because she was literally sobbing, and all she could really get out was that, "I'm sorry, Lauren, I didn't know. No one told me that you were at risk. Everyone told me you caught up and that you were fine," and that she was sorry. So fast forwarding to the Adult Preemie Advocacy Network. So as Morgan very kindly shared in that lovely introduction, our advocacy network grew from initially wanting to reach out and see if the things that I had experienced were quite isolated and were personal to me, or whether there were perhaps other people out there who may have had similar experiences. Once we connected, we found that there were lots of very similar themes, regardless of our gestation, regardless of our birth weight. There were issues in healthcare acknowledging our preterm birth, some issues at school, as Michelle just excellently highlighted. And we looked around and realised that there didn't seem to be a space beyond NICU in the early years that were addressing things we were seeing later on. So currently we have over 345 adults born preterm as part of our network. Part of the work we do is we run an open survey just to capture people's views and experiences. So within this, 20% report that their primary care provider does consider their preterm birth as related to issues and that they proactively monitor their health. But that strikes me as an incredibly small number. Another question we ask is, do you feel prematurity impacts your current health? Just over 84% report yes. Over 15% report that they're not sure. But again, I find it interesting that there isn't a no amongst those responses so far. And what adults born preterm tend to describe their experience like, having, I suppose, been told that they'd catch up, is that as we gradually get through this process of trying to unpick what's related to prematurity, what's genetic, what could be environmental, that this really leads to an almost roller coaster type of emotions and piecing together puzzle pieces. And the other communication we get very regularly is from parents of adults born preterm who are acknowledging that they are having to proactively step in to advocate for their child in healthcare settings. So this is just a few examples of assumptions and perhaps reactions that adults have experienced when trying to talk to healthcare providers about their prematurity. So things like prematurity is irrelevant, that perhaps the issues we're seeing are related to a laziness or a poor lifestyle choices. Things like, you made it out of NICU, you're fine now. And also that when trying to address this repeatedly, that this can go down quite a different track with assumptions of things like health anxiety. And I suppose if we all just take a minute to pause and just consider that as an adult, how does that make you feel? And what impact does that have on you to effectively have the fact of your birth history quite often dismissed? And what we realise now is that actually prematurity really isn't taught to healthcare professionals and to teachers as standard parts of curriculum and CPD. So it's no one's fault, but we all have the same aim, that we just need to be more aware. So another thing we really advocate for as adults is the importance that our parents do receive adequate support. So things like psychological provision should be provided in NICU and at discharge, but also on an ongoing availability basis, because people process traumatic experiences at different times and it may not hit home until later in life. And we'd also support and encourage families to share experiences of preterm birth and information with siblings and with the individual as they grow up. And also just to be aware of that wider daily support network for families. Are we doing enough to share information with grandparents, aunties and uncles, close family friends, so that parents don't feel isolated and alone in their journey? So, what is in a word? So when I started reading more about adults born preterm in the scientific literature, I noticed a little bit of a pattern when talking about adults born preterm, that often we're referred to as ex-preterm or former preemie. And this just led me to question whether are we giving the right message across to people that do not have experience of NICU or that knowledge or education. Because we all want the same thing. We all want our babies and as they grow to thrive. And we need to get this message across that birth history and time in NICU matters, and to ensure that it's included in birth records. So whilst we talk about physical health, as Michelle quite rightly said, we need to think about things like education, differences in things like executive function and mental health impacts. And something that members of APAN really report is that this systemic impact that prematurity can have, we tend to think about the big things like lungs and vision, but actually what we're seeing is things like blood pressure, musculoskeletal issues, endocrine issues, and people have a lot of questions about how this is affecting them as a whole. Often people report that the symptoms may be subtle and perhaps don't meet threshold and referral criteria. From the clinician perspective, I appreciate that sometimes what we're talking about could be vague. So things like tiredness and lack of energy could be attributed to a whole multitude of things. But it's really important that we take the opportunity to investigate. And there may be situations where these things are occurring only in certain circumstances. So just an example, exercise capacity. It may only be observable during PE lessons and sporting activities. Also, just to bear in mind that other areas of life can be impacted. We're aware that along with physical and mental health, things like work life, social life, relationships can also be impacted in a broad range of ways, and that these can also be contributing to stressful circumstances, and that in the long run this can contribute to overall health outcomes. So just something to bear in mind. So what can we do? There's plenty of research evidence out there that, as Michelle says, highlights the risk that we could be facing. So we really need to translate this evidence into practice. We need to raise awareness of the risks across society, as well as with individuals and families. So one suggestion is that we could utilise the use of the discharge summary and include a follow-up plan and recommendations such as Michelle has made. Because with thorough follow-up, we can mitigate risks and promote informed discussion and choices. Thank you so much, everyone. I really appreciate the opportunity.
Thank you so much, Lauren. Learning about your journey so far and just hearing you talk about your experience and your mom's experience, it's just really deeply moving, and a lot of it's really hitting home for me as a NICU parent. And you are just such an incredible advocate for yourself and for other adult preemies. And I really appreciate that you came on and spoke with us today. I know it's not easy to do, and I appreciate your time. So I'm wondering, it looks like Kira has a great question. Kira, do you want to come off and ask your question?
See, I think I asked a couple of questions in there.
Okay.
Yeah, I guess I'm just, Michelle did respond to my question that there is a good deal of literature exploring mental health challenges in the former, excuse me, sorry, now I always say former preemie. Lauren, see, that's the way I've always talked about my kids as well. So thank you for the language lesson.
It's fine. It's habit. That's all it is. It's
Yeah.
habit. And it just takes time and we just need to think about it. That's all.
Absolutely. Well, I appreciate that, kind of shining a light on that. But Lauren, I'm wondering about the network that you have built. Is that something that you also find pretty prevalent with those that are in the network in terms of, having those mental health challenges, whether it's anxiety, OCD, depression?
Yeah, definitely. And I think it's something that we really acknowledge, that family history can play a role. Being born early puts you at greater risk, but also something I think that we slightly question from the point of view that if there was greater awareness of prematurity for our parents and across our lives, and that support was there to advocate, would these mental health issues actually begin to decrease because we have the opportunity for support available?
Yeah, I feel like we had a lot of great early intervention services for my kids related to, sensory processing disorder, auditory processing disorder, occupational therapy, the speech therapy and all of that, but not necessarily for the mental health component. And it really, it was always like, oh yeah, she's just an anxious child, but she's fine. But I feel like there's got to be more that can be done much earlier, because we're really, it's a huge struggle right now.
So I'm going to share my screen real quick and show
Yeah.
you a preview of a graphic from the paper that we have just submitted. We had a total sample of 80 adults. There were about half of them, a little less than half, that were born pre-1990, and the other 45%-ish were post-1990. I kind of use that as a surfactant breaker. And of those 80 participants, 66 participants reported having a health condition. So the blue bars are conditions and the pink bars are medications that they used, or the number of people who used medications. So respiratory was, of course, the top, but really closely behind was mental health, although less medicated compared to, the management that was used for respiratory conditions. And also, pretty high were neurodevelopmental issues, and then vision and cardiovascular and endocrine. But, so the question about what happens when they grow up is that they still have some chronic health conditions that we need to make sure we're addressing. And this was an international sample.
Thank you for that.
Really helpful. Thank you for compiling that information. I see a lot of, Lauren asked, is there an average gestational age at birth? As it pertains to that chart, I believed.
So this was all comers, so it was 37 and less, because we realized that there's so much emphasis put on the smaller preemies and what we're doing. But for the adults who were born preterm, their gestational age appears to be less significant to them than the fact that they were born early, right? Because here they are, they're adults, they've gotten this far. So it's really this looks at all comers.
Thank you for that. Chantel, go ahead.
I can't help myself. You guys are just hitting every button for me here. Thank you for what you're doing, Michelle, and Lauren as well. A couple of things. I love, Michelle, to hear that your study is everyone under 7 weeks, because I'm a mom to 3 late pretermers. And the same thing, they're close enough to term, right? And the middle guy who was 34 weeks and had a short NICU stay was my auditory, my sensory, my anxiety, my depression, my apraxia, like everything, but it does matter because it didn't matter. Whereas I'm a 27 weeker from 1980 and had great follow-up and had great care, and somehow I'm okay like in the larger thing. But Lauren, thank you everything that you're doing for us as adult preterms, because until I heard your podcast with Mary Coughlin, I had no idea that I was at risk for kidney disease. Like, thankfully at 44 I'm okay for now, but I know in the back of my head, okay, I'm more at risk for this. I've had 3 primary care provider changes in 4 years now. Not one asks about my birth history or anything. I always spit it out. I'm like, by the way. And oh my God, there's just so much we could do with this topic. Like, I'm very fortunate. I don't know, Michelle, if you know the work of Dr. Saroj Sahgal up here in Canada. I'm one of her children in her study. And if it wasn't for that study, I would never have found out at 22 I had ROP and I had a giant hole in my retina. I had no symptoms, but it was like, boom, crap, you're in trouble. We got to get you in, right? And I still remember that retinal surgeon. He's like, of course, any kid under 35 weeks is at risk. Their retinas aren't fully formed. I'm like, what? Like, I was just finishing my nursing at the time. And I'm like, that's not anything you learn, right? Like, I think now NICU nurses and that don't even learn that. They just, because you only get screened for OOP if you're under a certain gestational age, right? And then I happen just to be nearsighted, and that's a double whammy. So yeah, I could ramble on forever, but just thank you everybody for everything you do. And Lauren, I'm in your Facebook group, so I try to answer all the polls and surveys every time
Thank you.
that I can get in there, because I want to help the future generation, right? That they don't go through what either you go through or what I've gone through or anything like that. Like, I'm so grateful I still have my eyesight now because of that study, right? Like, and if it wasn't for that, who knows what could have happened. So
yeah. Thank you. And if you're not following the chat, Michelle and Sarah have been just like answering questions just right in there. They've been like amazing about staying on top of this. And there's so much sharing of personal stories and so many like mm-hms and uh-hs and and hearing from Lauren and Megan and their lived experience. So I encourage you, if we haven't opened up the chat, please do, and feel free to raise your hand or send in a question if you have one. Go ahead, Malfi.
Yeah. Thank you, Lauren and Michelle. I'm sorry I was going in and out. I'm in the unit and I missed part of it, but most of the time I was on. So I know you answered my question in the chat, Michelle. I just wanted you to say it for the recording purpose. So how do we balance the conversation at the time of discharge when we are discharging the babies and families? And that's the joyous moment, right? So how do we provide this education and anticipatory guidance? Any tips?
So really, I think it's first about timing, right? So we wait till we get closer to the end, right? Because then they can hear you, right? I worked with a neonatologist for years who would ask the most ridiculous questions in the most inopportune time, and you just accepted it. That was him, but you couldn't do you can't do education, right? You have to get them while they're holding their baby and they're feeling good and they're getting ready to go home. and you normalize the conversation, though, it just becomes part of anticipatory guidance. So just like you're going to talk to them about good hand washing, just like you're going to talk to them about vaccine safety and making sure they keep up, all of these things that we talk about in terms of maximizing their health over time, that's how it has to be phrased. In my opinion, that's what I think is the most successful conversation, is not going, oh, now remember, they're really vulnerable and we have to worry about. No, it's about making sure they stay healthy. So let's make sure that we're doing the things, making sure that all providers know, and that the kids themselves, and we have gotten pushback from parents at different times when we've talked about this, because there are some parents who are so concerned that their child will be viewed as vulnerable, right? My favorite question was, well, is my child going to go to Harvard? I don't know. Did you go to Harvard? Right? Like, we have to start with level setting, right? Is my child going to be an Olympian? Does that mean you can't join the Olympics? Well, were you or was anyone in the family an Olympian? Because that tends to be something that is an athletic skill. Not so. So we start there, and then we talk about, well, let's make sure that we're making sure that they're not exposed to environmental toxins, that nobody smokes at home, that they just don't, try and steer them away from being a firefighter, right? Like, let's try and make sure we reduce those pulmonary risks to increase their pulmonary health. And some of that we can't control, right? Some of the environmental pollutants and the environmental issues we're not going to be able to control, because I can't change poverty in the United States. I just can't. But I can talk about the things that will help mitigate that risk and help reduce their exposure, not wearing your shoes in the house and all of those things, as an opportunity to try and help that and just make it a normal conversation. You do it a couple of times, you get used to it, and then it does flow just like normal.
Thank you.
Anyone else with questions for Lauren and Michelle? I want to say thank you so much to, go ahead. Oh my goodness, go ahead. We've got one hand raised. Thank you.
I'm sorry.
No, don't apologize.
Well, first of all, thank you so much, Michelle, and and Lauren for sharing your story, and Michelle for being such a forward thinker. Because as a certified neonatal occupational therapist, and I get so much pushback from providers that not only understand that just because a child is born late preterm doesn't mean that child is still a preterm. And then even after their discharge, as an NICU follow-up provider, I find a lot of resistance in getting referrals because, oh, baby's feeding. Baby went home feeding, or, baby is maintaining temperature. And really to understand that there are so many other layers that involve that neural development of that child. And as an occupational therapist, we have the lens to not only foresee what can happen, and the literature to support us, but also the ability to connect with that family and to educate them, not to scare them, but really because I'm a firm believer that family are central, and without talking and educating the families, we are not really servicing them. And a lot of the learning occur after the NICU, because during the NICU, there are a lot of information, a lot of education, but as you know, there is not a lot of assimilation and retention because of the stress level.
Right.
So if there is anyone in the Houston area, North Houston area that would love to, because that's one of my battle here. I used to work within a very large organization in Texas, probably the largest children's hospital in Texas in the country. And there's still the culture. They're still not acknowledging the importance of having not just any therapist. It has to be someone who's being in the NICU, who works in the NICU, who sees what happens on a daily basis and see what the families are going through, and then guide them after the NICU, especially during that transition between NICU and home. So I would love to connect with you all, Lauren, especially with your story, because there's so many families out there that are in the dark. And your voice is so precious. And thank you so much for all you are doing. Thank you.
Thank you. Thank you so much. And I hope that you will all join us for our next webinar on November 13th. We're going to have Deborah Bueller from NIDCAP and also our very own Kira Sorrells and Dr. Nicholas Embleton of the Butterfly Project presenting on that day, same time. If you don't have a calendar invite for that presentation already, please email me so that I can get it to you because it does already exist and we've got a lot of RSVPs and we're very excited. But thank you so much to our wonderful speakers today. This was a fabulous webinar and we are so grateful to each of you for your time and your expertise. And we hope that everyone has a great rest of your day.
Thanks for having us.
Thank you so much.